Ralph, I wonder if you could just, from your sort of health system CEO perspective, speak to the issue of the investment in the EHR, not just as a way to sort of deal with diagnosis and billing and everything, but really this bigger issue of employing big data to improve patient health.
No. Well, thank you, Dan. And as your question suggests, there's been major advances made the last decade in terms of using that data. But let me just note, with Mary on this call and me and Josh, three of the medical centers, but there's 100 medical centers like us in the country, and we share data. And in that data, we have shown when patients are treated longitudinally by the same health system, we save about 50%. That's a big 50% by having people cared for longitudinally in the same system through a variety of mechanisms that Kevin suggested. When people go to different places for care and move in and out of health systems, in and out of physician groups, in and out of practices, there's bad outcomes for patients and adverse outcomes for society who has to pay for this care. So part of what we have shown, if you really take responsibility for patients over the period of time, and then you do the kind of interventions that you and Kevin have both suggested and committed your professional career to, one can both get better outcomes and better costs. And I've been pushing that. So as you noted, having a common EHR, for example, Penn spans about 200 miles of geography, just like Dartmouth and Stanford do, from Lancaster, PA, for those who know the geography, up to Princeton. But when any patient comes in anywhere in that system, that information is immediately known to everybody else inside the system. Nurses, doctors, pathologists, radiologists, it's known. They can then manage that patient if she or he is seen by somebody else inside the system based on the most current information that they have. The pathways and protocols that Kevin mentioned that have been developed by our physicians and nurses and pharmacists, et cetera, are available there right on the computer in front of the physician or nurse who is managing that care. So that kind of integration of care, which still bedevils America. We have too much variation. Going back to my citation of the Dartmouth Atlas and Dr. Wenberg's inspiring work going back 30 years, it's still something we have to crack. But I think we have shown, and I think there's West Coast models like Kaiser and others, Intermountain, if you really integrate care, much better outcomes and much less cost. And I think we have to devote ourselves through the kind of mechanisms that Kevin notes, with good management, teaching, coordination of care that makes an enormous difference. Let me make one last great plug for professionalization of all these kind of services. As Kevin noted, as a country, we're not that great about adhering and complying as we should be. And we don't always take our medications. I think we have a professional obligations as doctors, nurses, administrators, all of the above, to really work to give best practice constantly to our patients. Many of you have been trained for 20, 30 years. You know an awful lot. You have to be able to impart that in an ongoing way. And Kevin and I have written about a topic we call automated hovering. I think we have an obligation to professionally hover over our patients. And these days, one of the most important breakthroughs in medicine in the last 10 years is called the smartphone. And that innovation allows us to hover over our patients and constantly remind them through nudges, as Kevin says, and other kind of mechanisms to make sure we constantly remind them how to do the right thing. And I think by doing those kind of things, using machine learning that then advances the kind of nudges that Kevin has talked about, we can go a long way towards better care and much lower costs.
Thanks, Ralph. One thing I hear you saying is that as well-meaning as clinicians are, they're overextended. They're piling additional things onto them and expecting them to make that decision is often very challenging. So the more we can build things in and automate things to do the right thing, the more likely it is to happen. I mean, that's what I hear you saying, and I know
and the advances in technology make that easier, both for the physician and the nurse or any member of the care team, but just reminding people constantly what the best evidence is and how to take it forth to the population that you're serving.
Yeah,
great.
Dan, can I add to that?
Please.
I think a lot of times the standard response to observed lack of great performance in many healthcare environments is to say, well, let's ask the primary care doctors to handle that. And well, having been a part-time primary care doctor for about 20 years, I can tell you that most primary care doctors feel overwhelmed by all the things they're supposed to do. And then all the things that are crammed into the short visit and all the reminders they're supposed to check, not to mention the acute issues which the patient came to them, which they actually want to talk about that day. And so I do think health systems writ large really need to do more of what Ralph was saying, really create systems that offload frontline clinicians, either with physician extenders or other ways of using technology to make it easier to both identify people who have health problems or unmet social needs, and then really providing tools to address them, because those tools typically are not in the clinician's toolbox.